A good audience yet again, hopefully, 276 registered. Thornton, I think I'm going to start. Other people coming in a bit late will just catch up along the way. So from myself and APMEN, Vector Control Working Group, a very big hello and welcome to everyone from all across the world, wherever you happen to find yourself. This is our fifth APMEN Vector Control Working Group webinar in the APMEN TechTalks series. This time on the very important topic of community engagement. They're all important topics, but community engagement, I think we all recognize is a critical element for success of any public health program. So just to introduce myself, my name is Leo Brock, Technical Lead for the APMEN Vector Control Working Group. And I have the great genuine pleasure of working with some wonderful people, including Dr. Tin Cho Thu, also Dr. Ponsi Hein, and then of course our APMEN Senior Director, Amita Chebi, who says hello and welcome and good wishes to everybody listening in. Thank you, Amita. APMEN, as you may or may not know, stands for the Asia Pacific Malaria Elimination Network, and it works very closely with APALMA, which is the Asia Pacific Malaria Leaders Alliance. APALMA and APMEN undertake initiatives in support of malaria elimination in the 22 member states they represent in Asia Pacific. So all of us are very grateful to you for finding time to participate in these webinars, for listening in, taking time off from the office. Thank you, Janian, for sharing this with us. So a bit of background on this particular webinar. Rural communities, often in the lowest income bracket, usually in poor infrastructural settings, in remote areas, often with inadequate access to medical care, are the hardest hit by malaria. And malaria is overwhelmingly concentrated in these rural and poorer settings with very basic housing, allowing easy mosquito access. People usually cook outdoors. They're close to rice paddies or ponds and pools of standing water, or close to forests and plantations. And this is where malaria flourishes. But here's the interesting thing. I have a personal little habit, often when in these rural settings, and there's a bit of time available, to wander around incognito, as it were, not known to be associated with whatever dengue or malaria work we're busy with. And I ask people, what are your biggest problems that keep you awake at night? You know, if you're lying awake at 3 o'clock in the morning, what is it that's keeping you awake at 3 o'clock in the morning? So their top worries are about not having a job, not having enough money to buy clothes or basic things for their children. They worry about lack of rain and risk of crop failure. For them, you get malaria and you suffer for a few days, you get over it, and you move on with life. Chronic poverty and its consequences are a grinding day-to-day reality of far greater consequence than the occasional bout of malaria. So, you know, if we sometimes get a bit frustrated by the lack of cooperation from communities in malaria control operations, let's consider their priorities and understand where they come from. And yet, the reality is also that these rural communities are not just the ultimate beneficiaries of malaria elimination objectives, but they're also the primary pathways through which we will achieve malaria elimination. And we need rural community people we need them to use their bed nets, to maintain their bed nets, to report for diagnosis and treatment when they're ill. We absolutely need their support to achieve malaria elimination. So that's what this webinar is all about. What is community engagement all about? How to achieve community support and participation. So forgive me, I need to spend a few seconds on how this webinar will unfold, and I'll try and be brief. We'll have 3 PowerPoint presentations back to back, each about 10 minutes in length, followed by a question and answer session. Everyone will be muted and the video off except for our panelists. Now, our audience members can submit written questions in the Q&A box at the bottom of the screen during the presentations, and I ask members of the audience to please look at those questions periodically. And if there are questions that you like or you support, then you can upvote those questions. Just click on the thumbs up icon below the question. And depending how many people do that, the question moves up the list of questions. And this is important because we won't have time to deal with all the questions. And I'm probably only going to ask the panelists to respond to the top few questions. Your vote will decide which questions go to the top of the pile. Then at the end of the webinar, we will put up a very short poll, and I ask, please, could you just take a few seconds to answer those poll questions, please? It gives us an idea of how we're doing and what we can do better. Please also note that this webinar is being recorded and will be made available on the APMEN website in a few days' time. Let's get on to the presentation. Tin, I think it's you. Would you mind placing our speakers on the screen, please? We have the pleasure of having with us today 3 top-rate people to talk to us on community issues. First up is going to be Professor Koen Peters Greetens, followed by Jocelyn Newcomb, and finally Dr. Tanang Su. And to these speakers, I think on behalf of all of us, please accept the gratitude from all of us for finding time to put together your presentations and be with us today. We really appreciate your expert inputs. Okay, our first speaker is Professor Koen Peters Greetens, and he'll be sharing with us some of his experiences and insight. And he's made a provocative title here, I love it. The impossibilities of community participation. Koen is head of the medical anthropology unit at the Institute of Tropical Medicine in Antwerp, Belgium. Koen, sincere thanks again. Over to you, and thank you.
Okay, can everybody hear me already?
Yeah, we can even see your handsome face, Koen. Go for it.
So I'll share my screen now. Good morning, everyone. It's still a bit of a dark morning here in Belgium as it's 7 o'clock. So when I started thinking about the presentation, I wanted to look a little bit at the concerns some of the colleagues have and people I know that work in community participation. And so I thought about doing it a little bit about the tension between expectations and possibilities and how we constantly kind of negotiate between both. And that's why I wanted to talk about the possibilities, but also the impossibilities of setting up good community participation. Now, in that sense, I wanted to start with the question, like, was it really ever about community participation when we do malaria elimination? Is it about community participation, or is it actually about effectiveness of an intervention? And if we look a little bit at the main premises, let's say, that full community participation would involve, we can actually see that many of them are not met in what we call community participation for vector control, which is okay, but it means that we kind of use a reduced approach to community participation for effectiveness of an uptake of vector control measures. For example, community participation involves communities being the main protagonists of social change. This social change, for example, has a very broad meaning that we don't always look at. There should be participation of these communities in public affairs in general, while our approaches usually only look at particular elements of malaria elimination, for example. A third element is that these communities are expected to become empowered. Now, empowered communities, it's something that we would hope for, but it's not an active engagement in most programs. It's also related to the interethnic differences and tensions in some regions, for example, that we usually not talk about. So empowerment, again, is a tricky thing. local forms of knowledge and action as a springboard for social change. I think we also kind of want that, but on the other hand, if we are realistic about this, I do not think we want to, or the aim of most of the programs is to negotiate, for example, the relevance of malaria elimination with communities, because we could be very surprised that probably people, like Leo said in the introduction, might not really lie awake of that at night. So we move then to something that is actually more about effectiveness than community participation. Now, if we look at effectiveness of vector control interventions, and we look at the main interventions, so what does this effectiveness require? One thing, again, we would all agree on that it requires engaging communities, but it is important to understand that there is no direct relationship there. If we think about it critically, we aim at engaging communities, but for example, Vietnam in the first decades of malaria control has had huge advances without any community engagement. On the other hand, engaging communities is required, but it's not a necessary or sufficient condition for effectiveness to take place. So what else do we need for an effective intervention? We need uptake, for example, of people have to use appropriate tools. And very often when we look at social factors, we then come to also acceptability at the local grassroots level. Now, some of the insights of working in community participation and effectiveness of control interventions in the past 15 years is that actually it was never about acceptability. I would say that it is highly overestimated. So again, acceptability is necessary, but we often make the mistake thinking that if acceptability is necessary, if we have acceptability, that then means that our intervention will be effective. And we very often see that that is not the case at all. In this study we did years ago on topical repellents in the Ratanaskari province in Cambodia, there was complete acceptability of repellents and their use. But when we looked at how often people would actually use it, there was only about 8% of the population that would use it. So a very acceptable intervention can still be not used at all. So what is important there, and it also applies to community participation when we look at this, is that there's a lot of social factors beyond acceptability and beyond also community participation that are very relevant and that we need to take into account if we want to achieve the goal of introducing an effective intervention. And I will quickly illustrate this with two small videos. These videos are from Vietnam. So on the left, now you should be able to see a village that is built by the Vietnamese government for ethnic minorities in this area. And as you can see, this village is more or less completely empty during the malaria and the rainy season, because although this creates direct access to all services, people actually, when they're in the malaria season, they need to work on their fields and they prefer to stay in the setting that you see on the other video now, which is in the middle of the rainforest of the mountains, because they have direct access to their fields. So this shows that malaria control interventions, to be effective, it can be acceptable and you can involve communities, but you also have structural factors, for example, mobility, people not being where they're supposed to be, people that are not registered. For example, when you have migrant populations, people that are not registered in the new settings, so that malaria control interventions or effective programs might actually in the end lose their effectiveness or not be effectively implemented because of other social factors. So this brings me to a couple of tensions that we notice when setting up community participation in vector control programs in general that I think are important to highlight, and they're a little bit structural, and that's why I would like to bring them up. The first thing is that with community participation and also making specific programs effective in specific local realities, we have to do this actually under universalist premises. And what we mean with universalist premises is that the whole malaria elimination paradigm, the whole, let's say, strategy is global. And you have these global interventions that then have to work locally. And there is a tension there. Everybody knows that there are no universal communities, right? There's no universal community that will participate. There is no standardized context in which we will carry out a project. So if there is no standardized community and no standardized context, then how do we apply standardized protocols, standardized SOPs, standardized tools, and how do we adapt them to this local context? Now, this worldwide standardization of information and audit infrastructure, for example, especially with NGO universities, but also at the level of malaria control programs, has a lot of advantage. It allows to measure and compare progress. You can compare cross-nationally. It caters to policymakers. It's a way of funding and evaluating mechanisms for disease control. It leads to accountability, but there is one big difficulty there, is that it creates a disadvantage to localize the interventions that we are actually expected to localize through, for example, community participation. If we look at, I just gave these examples, look at central Burkina Faso or the Vietnamese highlands or the Peruvian Amazon, or all these contexts that are completely not comparable. Most of the times, for example, we all have to work with the same type of bed net that in different local contexts might not be the most appropriate, might not be the one that people want. So how then do we contextualize interventions, and then how far can community participation contribute to this? I will quickly show this, an example of this with an example from Peru. Since we're all in Southeast Asia and everybody knows the context very well, I thought maybe it's interesting to give an example from the other side of the world. And that is this really critical relevance of having appropriate tools to localize. And this is something, attention, because we do not always have these localized tools. Very often we have standardized interventions or standardized strategies that are globally decided, and then we need to localize. Here, for example, in Peru, you see in the Amazon that people use the white net that you can see there. That's a little bit like a sheet. So it's a traditional net they have been using always, while malaria control introduces the net on the right, which is, for example, the standardized set net with bigger mesh, with this transparent, it's harder in texture. Now, what happens in this setting is that you have, like in some Southeast Asian countries as well, you have houses that have actually rooms and walls, but you also have houses that are completely open. Now, these nets are at this moment supposed to function in both houses. Now, one of the problems is that with this increasing heterogeneity and malaria transmission, and we also see this, for example, in Southeast Asia, the open houses belong to poorer people, so people that need more, let's say, support, more access to nets, more access to treatments. But the OLISAT nets, since they are transparent, are actually not as suitable for open houses as they are for the richer houses where you have different rooms. Because the people that sleep under these nets, the net is actually also their little room to sleep in. It's supposed to block out the outside. You're supposed to not see through that. If you have a nosy neighbor and you have a transparent net, they can just look into your bed net when you are undressing, dressing. So these are the things nobody wants. So the standardized nets for poor people in this context do not work very well. And here I give you a very quick picture where you can see this. So people there live in extended families together under one roof. So each, let's say, couple has one of these bed nets and the children. So we come to one of the universal premises there that nobody likes to sleep next to their mother-in-law when you're recently married, and have transparent nets in the same room so that everybody can see what everybody is doing under their bed net. So the transparent nets that are proposed as a standardized measure, however much you want to push those, or however much you want to use community empowerment, community engagement, community participation, you have these structural limits in this context that are very difficult to overcome. Another tension, let's say, that some people face, some might face it less and others more, or some contexts, is that we actually are required to reduce very complex contexts to some indicators again. As you know, the context of malaria now, for example, in Southeast Asia are very complex. You have, for example, indigenous minorities that have different languages, different habits than majority society. They live in remote contexts. There's a lot of poverty. They have different working structures, etc. But nevertheless, when we look at control programs and how we are supposed to implement programs and involve, engage communities, these complex realities are reduced to more specific themes and topics that are true, but do not really reflect the complexity of poverty and the general structure of these kind of communities. Just as a quick example, we all know that outdoor transmission is a problem. But if you look at some of the slides here, of course, what is outdoor if there are no walls? So there's only half of the place where people sleep is closed off. It doesn't invalidate outdoor transmission, but we expect that as malaria reduces and we look at the last cases, those are the people that are most exposed. And as in the study I put in the slide, when you look at entomological data and overlap them with social science models, for example, you see that more than half of the transmission in these cases is still indoors, because very often people don't even have bed nets. So a focus on outdoor transmission is good, but it's limited because we lose a lot of the context as well. The same with early biting. We always look a little bit at where is the gap. People are supposed to sleep under a bed net between 10 p.m. and 6 a.m., but a lot of the studies in kind of slash and burn communities, etc., have shown that like half of the population is already asleep between 6 and 7 p.m. and half of the population is already awake at 3 and 4 a.m. So in addition to that, when we look at early biting, is it early biting where? Some of these communities have very complex mobility and residential patterns. You can sleep in your village, or you can sleep at your forest field, which is a slash and burn field, or you can sleep at a wet rice field, or you can sleep where you have highland or dry rice. So there's a very complex mixture of outdoors biting, early biting, and people's residence patterns. And our focus on very specific elements makes it a bit harder sometimes to see this. The same with MMPs, and I will come back to this in a little bit. Of course, there are mobile and migrant population, but the question is, like the slide on the right, when you have people that live 6 months in the field, they are not really migrant or they're not really mobile, they're just there in the field. And we also see in some cases, like in the middle slide, in the study we did in Bujang Map, that actually the malaria peaks, for example, do not necessarily coincide when you have this mobility, because some crops that produce this mobility for work at the fields are not in the malaria transmission season. So we have complex realities. And the reason I go into this also is because in the end, we need methods and ways of setting community participation up that allows us to look at that. Another thing is we have changing realities. And this is an older painting, like the propaganda painting from Vietnam. But if we look at the reality now, and the people that have worked in Southeast Asia for a while have noticed this. For example, Ratanakiri, 10, 15 years ago, used to be all local forests. Now it's all plantations, so to speak, because these things relate to the global consumption and trade. So in this map, you can see, and you can look at the article yourself, all the red lines is where malaria risk is actually linked to international trade. For example, the demand of China for wood that impacts on Southeast Asia deforestation. Why is this relevant in our context? Because how do we deal if we use the regular methods we use for research, when we use the regular projects, the regular methodologies or implementation science methodologies to address this, or the regular forms of community engagement, when like the Rosewood and Odomingche, which is coming to an end, there is no longer a lot of this. Where will these people go? How will this impact malaria risk and transmission? How is the change from regular forest to rubber plantations that is going on now? How will that impact, for example, malaria transmission? And these are the tendencies now, but what can we expect in the near future in relation to malaria transmission? So we need methodologies, we need ways of setting up community engagement and methods that look at effectiveness, that allow us to look at these things. So how then, in my opinion, should we look at effectiveness, knowing that acceptability is necessary, but it's not enough? The localization of interventions is required, but it's not enough. Community participation is required, but in itself cannot be the magical tool to localize and make interventions effective. This community participation, as we all have seen, it requires long-term engagement, while depending on the organization, we only have sometimes short-term project goals. So how do we deal with this? We need to build up trust in these communities, but we are in contexts where we have multiple competing actors sometimes. And these actors are all people that work well and work towards community engagement and towards, for example, malaria elimination. But we need to ask ourselves as well, if I have a quick look at this nice document that Michael McDonald made last year. If we look at Cambodia, we have, for example, APMEN and APMEN, PMI, NAMRU, WHO, UN OPS, and the US National Institutes of Health. One second. Institut Pasteur, University of South Florida, the Institute of Tropical Medicine, NAMRU 2, CARE Australia, Malaria Consortium, PMI, Catholic Relief Services, MSF, CHAI, WHO, Health Poverty Action, University of California, San Francisco, etc., etc. So we have all these actors that are working in this context, in some countries with more or less coordination. So in certain of these contexts, that creates difficulty and competition among people as well. In addition to that, there is no possibility of setting up community participation without research. There are no universal communities. So we need to localize also the strategies that we need to really fully engage with communities and to understand their realities. Because if we do not understand their realities, we cannot set up a functional, good working engagement or participation strategy. And we need research into the localization and effectiveness of these strategies again. So what principles do we need for these effective interventions? It's very simple in that sense. We need a combination of research, implementation, and community participation in methodologies that integrate all three. This might seem simple, but a lot of research organizations, they're really not so much into implementation. A lot of implementation organizations actually don't want to spend part of their budget into research. And so then the community participatory aspect of it is not as functional as when we would go with complete methodologies like this. Implementation research is key. You have whole implementation science now. So we research an implementation and we continuously try to flexibly adapt this to the complexity of the context, to the changes in the context, to the limitations of the programs, to how people interact with us and how people react to the kind of interventions we are proposing. Now, this means you have what we call an emergent theory design or a flexible design. We need designs that are flexible. When we see something changes in reality, we need to be able to adapt. But this is, again, something that's hard to sell sometimes or to implement because it goes against this requirement of standardization and the classical type of interventions are like clinical trials where you have a standardized approach that can be measured and turns into international indicators. This approach also requires transdisciplinarity. We need to work together with all the disciplines we can get our hands on really to understand this complex reality and to do anything about this. Now, to finalize, one example of this among many maybe is the Community Lab of Ideas that we established and tested in a trial in the Gambia, and there's an upcoming publication about this. It's an example of where we try to combine these different types of approaches. So if people are interested, you can always later on look at this, but the basic is that a community participatory approach, and I think this is very important, needs to start from ethnographic research. And I know that for many people, this is not an obvious reality at all, and it requires a whole other presentation on it. But we need insights in local realities, and for that we need methods that can overcome the general standard reporting biases and also the bias of asking people what they want. Because we know that when you're implementing a project somewhere, for example, you come from a malaria organization and you're implementing a malaria project, when you ask people what really worries them, they will say malaria. So you need ways of overcoming this and have genuine insights in these local contexts. Then this information you need to create dialogues. And I think the dialogue, the word of dialogue is very important. It cannot be either way. If we ask communities just what they want, then they might not say, okay, we want to contribute to reducing malaria, which can have very negative effects on the communities themselves. And we also cannot just go in with our priorities and expect everybody to follow those. So the word dialogue is a very important way of connecting these two. Then there is a cyclical and iterative process between the components I described. You implement, you research your implementation, you set up your community participation, and your insights from your research feed into the community participation. The community participatory process feeds back into your implementation and your research. And at the same time, you try to do this in as multidimensional way as possible, trying to look into complexity, understanding the poverty, understanding work demands, understanding everything in relation to malaria and not just only malaria. I think those are a little bit the most important points. And when you put all of this together, you can have communities to be involved and co-create and co-implement specific types of interventions. But this is not possible without also having the different elements in the equation. So that was it for me. I hope this was not a lot more than 10 minutes. So thank you very much and open to all questions. Back to Leo.
Okay, Kun, that was a very thoughtful and stimulating presentation. Sincere thanks for that. Clearly, there's no one-size-fits-all principle for engaging or intervening or trying to help communities. It has to be contextualized in the local situation. You know, think globally, but you have to reduce that down to what is best and appropriate and relevant for a local situation. Thank you for all those insights. I'm just sorry that we didn't have an hour. I think you have a lot more to tell us, lots more, and we only have a few minutes, so that is unfortunate, but it's the reality of the situation. So we're now going to move over to Jocelyn Newcomb, who's going to talk to us a bit on community engagement, lessons from Asia Pacific. Jocelyn is an accomplished senior executive with 25 years of experience leading the design, implementation, and evaluation of malaria and other public health programs. And she is based in Phnom Penh. So thank you, Jocelyn. We look forward to listening to your insights.
Thank you so much, Leo. And thank you to the APMEN Vector Control Working Group for organizing today's session. It's such a privilege to be a part of today's session and to be together with all of you who share this commitment to community engagement, learning more about what it means and how we can do it more and better. So following Koen's presentation, we're going to briefly review some of the learnings from the region, several of which were discussed during an online workshop, which some of you may have joined with some of us, including Leo and others a few months ago. And we also discussed some of these issues during Malaria Week on the first day during the APMEN annual meeting. So we're going to briefly review some of those top line learnings and hope that it will trigger more discussion with all of you about next steps. But first, to kick this off, this is a picture from a recent field visit that I did with one of the vector control manufacturers to engage communities in designing and testing new options for vector control. And what I like about this picture is that it for me, it reminds me that community engagement begins and ends with listening to the communities at risk. Several of you have been a part of previous discussions regarding the definition of community engagement for vector control, and so we thought we would briefly review the definitions that we've all discussed together. What does community engagement mean? It is a participatory process. It is an iterative process, as Koen has just mentioned. It is a process in which communities at risk of malaria are actively involved, not just in the formative research phase, but in the design, the implementation, and the assessment of our programs. And although community engagement has been used effectively in a number of other health areas, it has not yet been integrated, at least at scale or systematically, into elimination efforts in the region. And the reason that all of us are gathered here today to talk about this issue is that I believe we all understand that traditional approaches, business as usual, are not sufficient to achieve the elimination targets in the region. And so we're here because we are committed to thinking critically and acting together to help our NMCPs and their partners do more and better community engagement for effective elimination programming. And we wanted to draw your attention to a recent review conducted by our colleagues at UCSF, which found that community engagement is often misunderstood within our community. Malaria experts and programmers often misunderstand it to mean social and behavior change communication or community-based interventions. And yet, what we're really talking about when we refer to community engagement is a more holistic and integrated approach to working closely with communities at risk to jointly or collaboratively design, deliver, and assess programs for optimal impact. So following a discussion that we had together during a previous online workshop with some of you, we thought it might be useful to just review the different stages that community engagement can be, approaches or techniques can be applied throughout a life cycle of elimination programming. Ideally, that life cycle is longer than a typical far too brief project life cycle. So if we're thinking about NMCP national strategies, which tend to be 5 years in the region, we can think about using community engagement approaches at 3 main stages. The first being understanding the needs and preferences of communities affected. How do we do that? How can we use community engagement to better understand the needs and preferences of these local communities that are affected? First is by co-creating the right vector control products to meet their needs and preferences. In addition to efficacy and safety, we need to be thinking about user preferences, and we need to be considering user preferences in the broader understanding of their their ecosystem, of their lifestyle, of their habits, of the way that they are living in communities. And as Koen has mentioned, conducting high quality ethnographic, human-centered design or other formative research to better understand the psychosocial and environmental as well as structural barriers and opportunities is critical to the understanding phase of our work. But that we want to emphasize it's not a one-off. This is community engagement for the best possible results requires a continuous feedback, input and feedback loop with the communities that we aim to serve. Secondly, when we think about delivering and promoting the right vector control products and services with communities at risk, there are a number of different ways that a community engagement approach or mindset can help us achieve more effective programming and better results. The first is to identify distribution outlets and channels that are already conveniently accessible to communities at risk. And those may be very different from the traditional channels that have been used in a given location. And so we need to continuously put the communities and the members of these communities at risk at the center of all of our programming decisions and efforts to make sure that we're not creating parallel systems that might work well for lots of reasons, but may or may not align with the best touch points and access points for these communities. And following from that, in terms of thinking about the mechanisms that we're using to deliver and promote vector control products, we want to make sure that we're aligning with their identity and influencers, which may or may not be consistent with the channels of delivery or promotion of these products that are traditionally used. We're using community health workers in a lot of countries, for example. To what extent those community health workers are members of communities of ethnic minorities and other community members who are at risk of malaria is worth exploring further. That may or may not be a barrier or an opportunity. And so it definitely warrants further consideration, pardon me. Moving on to how we think about the messaging to promote the appropriate and consistent use of vector control. We want to make sure that we're co-creating messaging with the communities at risk, and that we're thinking about promoting consistent use of vector control or practices, consistent practices in a two-way dialogue mechanism, as opposed to a one-way communication or discussion. Optimal vector control and elimination results will not be achieved through a billboard or a leaflet. And community engagement at its best offers wonderful opportunities for doing this well. And last but not least, thinking about integrating our delivery and promotion of vector control products with other services, perhaps health, perhaps non-health, which resonate with communities. So again, starting with what matters most to the communities at risk. I think we have quite a bit of evidence in our sector of the fact that healthier behaviors are often motivated by non-health focused interventions. And with the increasing support from donors and host governments for more integrated approaches, there are great opportunities for us to engage with communities for better results in that way. And last but not least, involving the community in the design and the execution of monitoring and evaluation of our vector control programs. We had a very interesting presentation on participatory monitoring and evaluation techniques presented by our colleagues from the Malaria Consortium during our last online workshop, which I encourage all of you to review. We can make those materials available. If nothing else, making sure that we're engaging our communities in learning about what's worked and what could work better is absolutely critical for the future. To briefly review some of the key learnings from our previous discussions about community engagement in the region, we thought it would be helpful to emphasize a couple of key takeaways from our previous discussions. One is that it's critical that we all understand that community engagement requires thinking and going beyond traditional information, education, and communication, and social and behavior change communication. It requires a dialogue approach. It requires ongoing multiple engagement with our communities at risk. Often it may involve community health workers who can serve as a bridge between programmers and the communities affected. But we need to remember that the engagement of community health workers does not in and of itself justify or should not in and of itself be equated with community engagement. Community engagement requires much more than working with community health workers. And in fact, it really depends on the who and the how, and the where and the when. So the devil's in the detail on that. And thirdly, community collaboration with local leaders. Sometimes those are the local political leaders, but increasingly, as many countries in Asia Pacific approach last mile communities at risk, this requires, looking locally at who the localized leaders are that are influential. They may be traditional leaders, they may be local religious leaders, and so making sure that we understand who those influencers are and working with them. Secondly, one of the other main takeaways that has emerged from our discussions in the region about community engagement for elimination and for vector control in particular is the importance of using non-traditional distribution channels. Starting with considering opening our minds to multi-sectoral delivery approaches, and recognizing that that standalone vector control product distribution channels are probably not the key to impact, to program effectiveness, and they're certainly present some unique considerations in terms of sustainability. So looking for opportunities, looking for the channels that are already reaching our communities at risk, and thinking creatively about how we can integrate distribution of vector control products into those existing channels is where we're all working to do more and better. And related to that, as mentioned earlier, there's huge potential to think beyond traditional health distribution channels and consider non-health channels. Many partners and several NMCPs are already doing this. And this is definitely an area that warrants further exploration and investment. Thirdly, we can't neglect the GESI, the gender and social inclusion component of this puzzle. Women and children and other social inclusion parameters need to be proactively and deliberately considered when we're approaching thinking about community engagement. And we'll talk a little bit more about that in a forthcoming slide. And just to emphasize that we understand that we need to be continuously distinguishing the context, the malaria context in Asia Pacific from the rest of the world. We are in an elimination setting in most countries in Asia Pacific, and that requires some very distinct, much more targeted and elimination appropriate approaches, which active engagement with communities can help us to do. We had a really interesting session with some of our colleagues in the previous online workshop that we wanted to share some key takeaways from with all of you today. And basically this boils down to emphasizing the benefits of normalizing the role of women and girls in vector control. And just as we're bringing a gender lens to community engagement, of course, we also need to bring a social inclusion lens. We can't separate the SI from the GE in GESI, and that just that stems from the reality that engaging women in vector control programming has massively positive impacts on gender equity, on sustainability of our programming and the results, as well as health outcomes. And we walked through with our colleagues who shared some work that has been done through a project known as Accelerate to Equal. It's been published in the Malaria Journal, and some of the key highlights from that previous work are that it makes a lot of sense to think critically about whether we are doing enough in the vector control sector to assess gaps in women's involvement in vector control at household, community, and professional levels. To actively look at whether we are actively promoting the role of women in vector control well enough, and to prioritize women's employment in vector control as well. And you can see on the right-hand side of the slide some much more specific checkpoints for all of us to consider as we are building our community engagement plans together. The good news for all of us is that there are innovations that are coming down the pike, which have massive potential to make this hard work. Maybe it will still be hard, but a little bit more feasible. And we wanted to highlight 3 of those for all of us today. The first is the digital health space and all of the innovations that are rapidly making it easier for us to engage communities more quickly and more continuously for that active input and feedback loop that we've started talking about today. And secondly, that just to recognize that there are countless technological advances coming down the pike that have potential to enhance the quality and reach of vector control programming. And that leads nicely to the next area of innovation, which is the product innovations that the manufacturers and our product development partner, IVCC, are working on. These are critical in terms of addressing the current gap in terms of the right products, right? We need products that address the needs and preferences of communities at risk. That includes products that are effective, that are safe, and that can be used in settings where outdoor biting and resistance are of concern. And so fortunately, we have some innovations coming down the pike. We certainly need more and better, and we need to make sure, as IVCC and its partners are, that we're engaging communities in the design, the testing, and the rollout of those innovations. And last but not least, the potential for new delivery mechanisms, whether that means integrated delivery of vector control products with other health or non-health products and services, and some of the other integration opportunities that we've covered already. To close, we wanted to highlight some of the priorities that have been identified in the region for further investment and exploration together, and we look forward to discussing these opportunities about which of these you feel are the most would be the most impactful towards supporting elimination in the region. Some of the suggestions that have been raised by all of us in the past include the need for a more focused and detailed review of the use of community volunteers, both health and non-health. So that includes, for example, community rangers working with forest goers at risk and others, but to review what's already happening in this space against the principles and best practices of community engagement, so that we can identify more specific opportunities to replicate, to adapt and replicate these approaches across the region. Secondly, to purposely bring a gender lens to inform, deliver, and evaluate vector control programs in Asia Pacific. Most of the good work, although some of this has been piloted in Indonesia, a lot of this work has been done outside of our region, and so there is increasing recognition of the potential for us to strengthen vector control and therefore elimination outcomes by bringing a gender lens to these programs in a purposeful manner. Third, developing standard operating procedures for some of the specific components of community engagement to make it easier for NMCPs and their partners to adapt and replicate best practices. We've been talking about these concepts now for a while, and there is, I think, momentum building for us to go beyond talking about what community engagement means, and more specifically into how it's being done, how it can be done better, and how it can be done at scale. Obviously, scale in the targeted context of the elimination context in our countries and in the region. And then fourthly, making sure that we're fully abreast of the digital health advances and looking actively to leverage the full opportunities there. And last but not least, just making sure that we are continually thinking about how to tailor best practices in community engagement and future investments in this highly impactful and promising area to ensure that it aligns with our context in the region. That includes, thinking critically about how to use the most, the most effective, the most pragmatic approaches for NMCPs in the region to adapt and sustain, given reduced funding levels, and given, frankly, the very high levels of commitment and capacity in the region. It's definitely, we have an advantage in the region to build on these best practices in ways that can be led by our NMCP partners with support, and that I think is quite exciting. With that, I will pause and turn it back over to Leo. Thank you.
So, Jocelyn, as usual, very well done. I love the way you categorized and packaged that life cycle of community engagement into three meaningful packages. There was one thing that I thought I'd like to mention, is that for me, one of the key measures of how successful you've been in engaging with communities is sustainability. And NGOs and projects go into a community and they bring to bear interventions, but funding realities is the project is only 3 years or 4 years in duration. Those people, having done wonderful work, they withdraw, and then this is where it becomes critically apparent, how effectively have you embedded those lessons, those interventions that you want to benefit the local community? How well have they been taken up in a sustainable way so that communities can move forward themselves with whatever it is that you've tried to help them with? So you've distilled a wonderful broad range of issues into nice bite-sized chunks that's easily understood. And I, for one, am very grateful for those insights, Jocelyn. I think you did a great job. Somebody, hopefully Ms. Jocelyn Newcomb, should put this in writing as a case study. It's such a neat summary, and it deserves to be written up and parked somewhere accessible to everybody. Well done, Jocelyn.
Thank you, Leo.
So now we move on to what I'm really looking forward to as well, is the presentation by Dr. Tandang Su, and he'll be talking to us on engaging communities for better vector control outcomes, specific to Myanmar. So Dr. Tandang Su is the Director, Health Literacy Promotion Unit in the Department of Public Health, Ministry of Health and Sports in Myanmar. We look forward to what you have to share with us, Dr. Su. Thank you so much. Over to you.
Thank you so much, Liu and all the participants. It's very good afternoon according to Myanmar Standard Time. So very nice to meet you all. I would like to present engaging community for better control outcomes. That is some of the reflecting some of the example what National Malaria Program in Myanmar is already achieving. So please let me share my screen. And my presentation outline is we will start from the malaria situation in Myanmar, and then program timeline and focus, key intervention and supporting elements for the NNCP. And what we are doing now is the integrated community malaria volunteers and how to engage and better engaging community in better control. So I would like to present this one. So in Myanmar, we have already 52 million population and 22.3 million population are at risk of malaria. There's a lot of malaria cases, like 53,000 malaria cases and 14 malaria death in 2019. However, compared to the previous decade, something like that, that is the morbidity and mortality line is like very in the downsloping or something like that. Now we have facing more problem with the buybacks rather than the facet brand. And the primary betas, what we have is the non-fleet direct and non-fleet minimus. So we have developed a global technical strategy, and also we have developed a national strategy plan towards malaria elimination. So our target for P-facet brand elimination is by 2025, and all human malaria species by 2030. So community and private sector engagement is the key focus in elimination. So the key intervention, as I already mentioned, is like the early and effective malaria case management, universal coverage of high-risk population with appropriate malaria prevention control measure, case-based surveillance, and research, and creating an enabling environment. So success to this decline is we have reduced up to 89% morbidity reduction and up to 99% mortality reduction from 2012 to 2019. So the biggest stakeholder and the biggest contributors to this achievement is the frontline community workers and private outlets. Now we have more than 21,000 integrated malaria volunteers. Previously, we called them as malaria volunteers or village malaria volunteers, something like that. However, according to declining situation of malaria situation in many parts of the country, we would like to rename them like integrated community malaria volunteers, so that I will explain in the later part. So another part is like we have a lot of partners like international and national NGOs, ethnic health organization, and private sector. They are also very big contributors to get this kind of achievement in our countries. So that is the one talking from big case. I believe that if you show people the problems and you show them the solution, then they will move to it. So that is the great saying from the great cooks from big guys. So what we have done in our country is we have to inform the people what is the benefit of the better control, benefit to take part in the malaria elimination and malaria control as volunteers, something like that. And then we can recruit some of the people, especially from the very hard to reach and remote area as our volunteer, so that we have NNCP have like 15,000 volunteers and partner have more than 6,000 volunteers. Like their primary role is like malaria diagnosis, treatment, referral, and information, education, and social and behavioral change activities. And all together, they have to come along with the TB, HIV, leprosy, dengue and filariasis control, and post-expression, any disease, they can refer and follow it, something like that. So that is kind of like we are putting and changing the malaria volunteer as like the workers, health workers, not only for malaria, but for the other health-related matters like volunteers in the community, so that they can sustain, they can get respect from the villagers, and then also they can continue their work as volunteer because they left volunteerism, something like that. So that is also we have to promote this kind of idea. So according to the 2018 figure, we have mapping of malaria activity. So malaria volunteers are like distributed all over the country. So especially in the high risk area near the borders and some of the area which already have many forested areas, something like that. So there is a lot of volunteers. So there is one dot represents a cluster of volunteers in this area. And also we have NSCBF developed a manual for the integrated malaria volunteer since 2017, and this volunteer is using by the NSCP to train all the people in the country. And there is a distribution of the proportion of the volunteers. So many area you can see that the highest volunteer density is in the highly like malaria prevalent area, like in Rakhine State, so many area in the country. However, we need to like more focus and more target to the malaria prevalent area, because some of the area in the northern Shan State and some of the area in the Rakhine State stay in the conflict affected area or something like that. So we need to promote more volunteers and more community-based service in this particular areas. However, there is a big job to be done. So that is and also the many finance agency like Global Fund. That is one of the right to E activities through ICMB. So that is like not only doing for the malaria, they also give other disease education, something like that. And in order to take part in the better control, like they have ICMB training and also the other diseases, something like that. And I would like to show this one. Yes, and also the volunteer training, because even the people in the remote area, we think that they are very remote area residing people. They have very low education level, and sometimes we think that they cannot be done something like that somehow. However, they can catch up very easily. So that is the one of the malaria training from the PMI malaria and the URC malaria. So they have done very good training. After that refresher training, the knowledge score are improving among these integrated community malaria volunteers. So this is another example of the malaria. So she worked in the Shin State. One of the in study, she said, now all the villagers are in the habit of sleeping with mosquito nets. They even use them when they go to the mountainous area or seasonal cultivation, something like that. That is kind of community like role model. The volunteer became the role model. They can ask other people to do the take part in the better control activity. They would like to protect themselves, something like that. So that is another area of good ICMB example. So as I already explained, there's many rules because NSCP in Myanmar is also thinking we need community-based services. We need community participation up to even after the malaria is eliminated, because malaria, when we are moving towards malaria elimination, we can have like many like recurrence or infection. If we don't know, like if we have weak surveillance activity, that can lead to be outbreak, and it will like very like disturbing to our achievement in the malaria elimination status, something like that. So we need continuous community awareness and also community participation, even in the low malaria settings, something like that. So we would like to train these people which not only for malaria but also the other health interventions, so that they can sustain their services and they can get more community participation, something like that. So like in low transmission area, something like that, like village has volunteer or ICMV along with the health staff should be actively involved in the case detection and reporting, measurable case and foresight investigation and response. So that is also what we are doing with the ICMV. So they are take part in the, like not only in the better control, but also in the early diagnosis, referral, foresight investigation, even in the foresight management. They are taking part in this activity. So that is the selection process for the volunteer. That's also very important. Like we have the township health committee, usually led by the township medical officer and township general administration department. And we also have the village track health committee, the health staff and village administrator and village track administrators are already there. So they can select the volunteer, like they have to be like active in a social work with some level of education, something like that. So that is kind of selection process for the ICMB. So those ICMB should live longer period in their villages to sustain their service, something like that. So the village health committee and the health staff in the area, they already know the people, so they can select the right people. So that is another area ICMB is taking part in the vector control and airline and distribution activities. And there is also the ladies, Room More. She's asking people to sleep in the back nest, and also IRS activity. There is also sometimes ICMB taking part in this IRS activity. So that I would like to go back to the some policy level and some like strategically thinking level. So what our WHO DG is already said, disease such as malaria, dengue, leishmaniasis, and lymphatic filariasis, like we can like put the better control not only for malaria, better control all for all the beta-borne diseases, something like that. So that is the very the second strategy is like engage and mobilize community. That is also very important. That is also mentioned in the WHO document for the comprehensive better control, something like that. So there is also the, if we would like to people participation, if we would like to get the more community participation, we should start from the individual level. This is one of the model from the socio-ecological model in 1979. So it starts from the individual level. So like individual level, we can start with the volunteer. They should have the knowledge, skill, benefits, value, efficacy, something like that. However, in the community, like community is already like the people who are sharing the same area, same culture, like same knowledge. So that is the definition of the community. All you have already know, and they also have the like peer groups, like the father and mother to the children, like ties and peer groups among the friends, among the people in this community structure. So family and peer networks is also very important. So they should ask people what to do, what not to do, what about the better control, what about the other disease rather than the beta-borne diseases like non-communicable diseases, even in the like kind of COVID-19, they can ask and they can remind among the family. And also according to the community structure, they have the leadership role. Some of people are also the influencing people in the community, so that we can take part in our intervention, so that we can get like some structure and some infrastructure and some resources in the community that can lead to later like the health capital and the community capital against malaria elimination, something like that. So this kind of community structure we need to understand. We need to take part all the community structure. So that is also very important, and also the peer pressure among them is also very important. So that is, we need to have the skill stuff from the self level, information, motivation, ability to act, and also the social norms in the communities is also very important. Something like that, the people are not sleeping in the bed net in one village because they have no habit or they have no knowledge and they have no socio-cultural norms that they are using bed net. However, we have to promote the use of bed net, use of better control option to convince them and to follow up with our better control activity. Sometimes it is very difficult because it is culturally or socially not acceptable. However, with the help of the volunteer, they start to follow. Like we have many experience in the Chin state, near to the Rakhine state. Some of the village, they don't want to sleep under the bed net. However, we have to negotiate. Now they are now using the bed nets, and I think this is the most bed net utilizing area in the near the Rakhine and the Chin state, something like that. So that is the theory of planned behavior. So they start from the attitude. Subjective norms among the community is very important. So they would like to accept their behavior is good, and then they will perceive that behavior control, and that lead to another intention, and that leads to also the repetition of this protective behavior. So that is another example for the diffusion of innovation. So some people start in a community as volunteer, health staff, or health worker. So people will follow through their ways. what it is already set in the diffusion of innovation. Some people we have laggards like on maybe 16%. However, we need reputational activity, we need family peer network, something like that. So we can increase, we can reduce that kind of laggards population in this particular community. So there is also IBM framework. So it's also point out the integrated approach, capacity building, collaboration, advocacy, social mobilization, and legislation is also important. Sometimes the people behavior is very difficult to control. At that time, the legislation and there's some kind of legal behavior, like digitalization, some of the activity is also important, and also research is very important for the evidence-based decision making, something like that. So that is the IBM checklist. So a lot of intervention we need to put to get a the integrated better management program, like program administration, financial aspect, equipment, surveillance, control, public education and relation, intergovernmental research, emergency response, and also the training. So there is a lot of component in the integrated better management program. And that is my last slide. So I would like to deliver my take-home message for you to get successful better control, to get the successful malaria elimination program. We need surely community participation. Without community participation, we cannot even move toward malaria elimination. So that is very clear. So to get the community participation in malaria elimination program, we need to target, form the community structure, or form the volunteer structure or networking. We need to empower, we need to support, we need to follow up, we need to monitor evaluation until they have the sustainable community ownership among themselves. So thank you so much. I would like to get it back to Leo, and thank you so much for your time and your listening. Thank you.
Dr. Tanang Su, what a powerful ending. Just such a positive, strong ending to your presentation, summarizing and putting together what needs to be done and the importance of community engagement, community participation, community mobilization. So an excellent talk to give us some understanding and insight of what is going on in Myanmar, and not only did you point out, some of the practical issues in Myanmar, but you underpinned it with a lot of theory as well. So a wonderful holistic approach that I certainly found very useful and enjoyable, and I learned a lot from that. Thank you sincerely for that, Dr. Tanang Su. Really excellent presentation. So we are well over our allotted time. We're now at 1 hour and 18 minutes. So unfortunately, we're not going to be able to take too many questions, but let's ask a few questions and see how we go, but we don't have all that much time. So here's a question here. And maybe this one should go to Kun, but let's see who's willing to answer it. Are there examples of regional universities with social science or anthropology departments and students who can be engaged to support these localized community dialogue best practices? So Kun, it's the question from Michael McDonald. You interpret it in the way that you feel best. Do you have any comments you'd like to make on that one?
Yeah, sure. I assume you can hear and see me because I still see.
Yes, absolutely.
We have and like the ITM has had a framework agreement with some regional, either national malaria control programs like Nimpe in Vietnam or CNM in Cambodia, and through that we have recruited some students from universities. We have a couple of people we trained from Phnom Penh, for example, also in Vietnam. Unfortunately, until now, we do this just with the available funding, and it's not a very structural thing, but we're aiming to get these people at least up to PhD level so that they can then lead the search and training for these kind of for similar profiles of people locally. But it's not so easy to find the right people to do these kind of things, because I think we just need to build more capacity, especially in the social sciences in Southeast Asia. Like in Cambodia, for example, universities are still relatively young due to their history. There's a lot of good people there, but we need to train more. We have been trying with some other organizations to get a workshop going together. Maybe we could do this with ITM, maybe APMEN or other organizations, to really focus on the requirements of social sciences for vector control. So we hope that at some point we can find funding for this and we can keep on training people locally. So it's part of what we try to do, and there are some examples, but it's limited, unfortunately.
Thank you, Kun, for those perspectives. So let's move on to Jocelyn. A question for Jocelyn, maybe. National malaria control programs do what they can with limited budgets, staff, and other resources, but it's never enough. So do you think that there is adequate partnership between government and private sector in confronting the malaria challenge? And as an example, is there sufficient engagement of NGOs with expertise in community issues taking place? If not, why not, do you think?
Thank you, Leo. Great questions. And as we all know, our region is quite diverse. So it's difficult to answer a question like that for the region as a whole, because the context in Papua New Guinea compared to the context in Vietnam, very, very different, both in terms of what types of support I think the NMCP partners are asking for. Also in terms of the funding landscape, the domestic financing contributions, and also the partners. I mean, there was a reference from Kun to the very large number of implementing partners working in a country like Cambodia, for example, but there are others where that list is much shorter. And I would say that I think it's good that you're helping us raise the resource issue, because we need resources to support this work. As the cases fall, that last mile coverage and motivation becomes sometimes more complex, sometimes more expensive. It doesn't necessarily mean that the last cases are going to be easier and more cost efficient to find. So I think we need to be thinking creatively, helping our partners think creatively about how to mobilize the resources that are needed. And I think you're right to flag partnerships as an opportunity to do that more and better. I personally have seen great engagement with private sector and civil society partners in the Greater Mekong subregion, which is the region where I've been working and living for the last 11 years. I think Myanmar is renowned within the region for their strong support and genuine collaboration with civil society and private sector. And it's worth congratulating them. And they're really, demonstrating leadership in this respect. It's one of the few countries in the region that has a private sector engagement strategy for elimination, which is designed in a highly consultative way with a number of different of private sector partners. So I think there are examples of some really bright spots for us to learn from in the region, and hopefully going forward with the next with the next phase of program strategy development and program design, as well as proposal development, we can all think creatively about how to integrate community engagement best practices into our plans through partnerships, and how to advocate with with funders as well as host governments as domestic financing becomes critical to achieving elimination and sustaining elimination in the countries where we're quite close. Thank you.
Thank you, Jocelyn. Yeah, hats off to Myanmar for the kind of work that they're doing. Dr. Tansu, this touches on a question that was raised by Effie Espino as well. One of the questions I picked up is community engagement is an integral component of public health interventions. In Myanmar, are these community engagement initiatives fragmented and targeted at specific diseases, or are they integrated and address multiple diseases simultaneously, or is it a mix? And which do you think is most effective? You've already touched on it a little bit during your slide presentation when you said, you know, dealing with filariasis and various other mosquito-borne diseases. But, you know, one thinks of your reference to sustainability into the future, post-elimination, and the need to maintain awareness and readiness. And that presumably implies, you know, a cross-disease approach. Any comments from your side? What approach are you adopting in Myanmar, and any opinions on your side to improve effectiveness?
Yes, I would like to say that in previous time, like we have like many WHO disease program like malaria, dengue, not only the vector-borne disease, other like NCD program. We have many program like health promotion program, so that like all the like program activities are like targeting up to the basic health service professional level, and then up to the community level, so that like all the program activity is like somehow fragmented. So you are correctly said about that. However, in this what we would like to say after in this previous government period, and now the continuing government period, we have to like integrated all the approaches, so that like community engagement, community is the first. Like our state councillor is already saying that even in the COVID-19 area, the people are the major contributor. So people are first. People have to prioritize what by all the means, something like that. So now we are like engaging community, and we are now combining all the fragmented approach to into the integrated approach. So we will have like the social capital, social health capital in the community, so that we can do many things. Like we are now promoting like one member of each family to become a health awareness personnel or something like that, so that they can have the peer education among the family, and then to the community level, so they can share the many health-related healthy lifestyle, health-related information, how to utilize the government services, how to utilize the services from the private sector, something like that. So that is what we are moving forward and what we have changed already. Thank you so much, Steve.
Yeah, no, thank you so much, Dr. Su. So insightful that. I'm going to try and speed up a little bit because we're well beyond our time. So Kun, as a leading international academic with loads of experience across the planet, for guidance of prospective upcoming anthropologists, MSc and PhD students, or NGOs working in particular areas. In your opinion, could you point out maybe one or two key areas that need particular research attention in terms of understanding or improving the whole community engagement, community mobilization, community sustainability in their participation process? Where is our knowledge still particularly poor? Where would you guide people that would like to contribute to improving our understanding and abilities? where are the gaps that we need to focus on at present?
Yeah, maybe two very quick answers to that. I think one of the first things is, one of the gaps is in the methods, because we, like I said in the presentation a little bit, we're always caught a little bit between this hierarchy of standardized methods and then trying to push for more flexible methodologies and flexible ways of operating, like what Jocelyn also showed in her presentation, which is really necessary in this context. So there are some new theories like on complexity and all of this that we could use, and on like transdisciplinary designs and all of this, but this is not so easy. So I think methodologically is one thing where we still need innovation. A second thing, although it seems pretty obvious, but I think there is still a big gap in our understanding of the structural factors that lead to people in increasingly heterogeneous contexts, because malaria is increasingly confined, so it's increasingly higher in contexts that we do not understand that very well, and how to understand the structural limitations and the way these people live and its effect on how to set up interventions. I think we know, but we don't. We think that if we implement something in a specific way in these settings, that we know what results to expect, but very often even actually we do not know, because like I said, these contexts are so heterogeneous and change all the time that we really need to focus more on the structural elements that define people's lives in these contexts. And it's pretty obvious, it's not a very big thing, but it's something we actually miss a lot, even today.
Yeah. Thank you, Kun. Thank you for that. So one to Jocelyn. Jocelyn, malaria is not top of the list of challenges in the lives of most rural people. We've made reference to that. Despite the importance and the life threat of malaria, there are other realities to life. Ultimately, the real solution is improved quality and standard of living. So people live in homes that offer better protection against mosquitoes, where they can cook and socialize indoors and so on. Do you agree that we should be spending more effort and resources on job creation, income generation, livelihood improvement than we are currently doing? Is there, that you're aware of, is there any such work going on among communities that jump to mind that you could highlight? It's kind of that issue of building out malaria and building out dengue through improved housing and standards of living. Any comments on that, Jocelyn?
Thank you, Leo. I think that, that this question really gets at the heart of what community engagement means. And going back to that wonderful UCSF review where they highlighted, the importance of understanding that community engagement means bringing a holistic and an integrated approach to our work. And if we're putting communities at the center of vector control program planning, design, execution, and assessment, then that's a very different approach to coming at this as a vector control specialist or even a public health expert. And so, as I think you're really rightly emphasizing, it's so critical that we take the time to understand what's important to communities at risk, and then build from there. I think that integrated public health and livelihood interventions. I mean, that model has been demonstrated and validated globally through a number of different health sectors. The DREAMS model, which is being funded by PEPFAR for HIV and AIDS with adolescent girls and young women, is a perfect example of that. A little less relevant for us here in Asia Pacific, but the point is that there's been a lot of research and evidence generated about the value of those integrated approaches. And I think that's why we're here talking about this today. I also just want to come back to a point that we talked about in my session, which is that healthier behaviors or practices, including consistent and correct use of vector control products, are rarely motivated by health alone. It depends on the community. It depends on the individual. We might have some cases where a mom really cares about her baby's health, and that's going to work. And that health-focused messaging through her antenatal or her under 2 or under 5 clinic visit is going to work. But there are a lot of others where, you know, if I'm a 28-year-old forest goer and you're coming to me and talking about my health, I've got much bigger problems in my mind, and so it's about the value proposition for the communities at risk, and learning more about what's keeping them awake at night, and then figuring out how to engage them in understanding that vector control practices have the ability to address the things that they care most about, in addition to protecting their health. It's all interrelated, but we need to take the time to do that carefully. Thank you for that question.
Yeah, huge issue. Not so easy to solve. Yeah. So, Dr. Tan, if I may ask you, in your opinion, if you look at Myanmar and also the other GMS countries in the region, where we are closing in on malaria elimination, but the challenges of residual malaria are still formidable. Are there particular aspects where communities could help to bridge that gap, to help achieve elimination? Just that final mile, that last push. What are the 1 or 2 things that communities could do to really help to bridge that gap that we are struggling with? We are so close to malaria elimination, but it's proving a little bit more difficult than may seem to be the case at first glance. How can communities help to bridge that gap? Any ideas, any suggestions from your side?
Thank you, Leo. That is a very big question. So I think this is like when malaria is moving towards elimination, like people feeling like their perceived risk and their perceived perception to the malaria risk became very lower and lower. Sometimes some community may forget about malaria. So that is the big challenge, and like all the donors, like even the local administrators, even the member of parliament, they will not put malaria in the priority list. However, this kind of problem, we would like to already Jocelyn already said, we would like to give our services in packages, something like that. So we need to promote malaria along with the other health-related behaviors, or NCD is now very prevalent in much of the area. However, when promoting NCD, protective behavior, at the same time, we would like to put malaria in the highly agenda or something like that. So that is we need continuing the people awareness, something like that. So sometimes the intervention may be different from one geographical area to another area, like some kind of residual malaria in the area, so that this kind of area we can target at more our malaria related activity in this particular area, and all the whole of society approach, like what we need to also advocate our government, like getting malaria elimination status, to get more tourism, like more to get more economic development to countries, something like that. So this kind of continuing advocacy, continuing getting the political commitment is also very important. So we need not only in the particular specific focusing community, we need whole of society approach, whole of government approach. So we need to promote malaria intervention in packages with the other health interventions, something like that. Thank you, Leo, for this very big
Excellent. Not easy. There are many more questions. Unfortunately, we do not have time to go through all of them. I promise you, to our audience and the people who have not had their good questions answered, we are going to collate all your questions, and we are going to send them to our panel of experts, and we're going to ask them very nicely, would you mind taking a few minutes of your valuable time just to write down some quick answers? There are some short, easy answers to some of the, not easy answers, but answers that can be made fairly succinctly to the questions that we've left unanswered. So to our audience, thank you so much. The presentations will be made available. There are some questions about that as well. I think there's a holding slide that will come up, yes. So www.apmen.org. The presentations will be posted there. Give us 2 or 3 days, but the presentations will all be on those websites. I think it's been an absolutely wonderful webinar. Thank you so much to our wonderful presenters. Thank you to our audience. You sat through almost 1 hour, 45 minutes. And we ask you just to spend a few more seconds to answer, go through this poll. It's just a few questions, won't take you very long. But to our panelists, to our wonderful audience, to each of you, a very sincere thank you for your time and for sharing this opportunity with us. Thank you very much. Have a great day.